Thank you, Sages, for the invitation. I'm here to present the data on behalf of our group to answer the question that we had, which was, are abnormalities on the preoperative HRMs associated with development of the GERD postoperatively after a laparoscopic sleeve gastrectomy? This is our financial disclosure slide. So as far as background, GERD is the most common complication after laparoscopic sleeve gastrectomy, and as we all know, it is a coexisting comorbidity with patients with morbid obesity at baseline. And while preoperative endoscopy has been recommended by bariatric societies, high-resolution manometry, or HRM, is not routinely recommended as part of the evaluation. At our center, although, every patient that is getting evaluated for sleeve gastrectomy does get a high-resolution manometry, and we therefore dug into this question to see if there was some data to help us. High-resolution manometry, as we know, helps assess the esophageal motility and the functional anatomy of gastroesophageal junction, which may further help elucidate the mechanisms for reflux in these patients. So for this, we designed a retrospective cohort study where we looked at patients who had laparoscopic sleeve gastrectomy performed between March 2012 and July 2023. And we broke the study populations into two, Group 1 and Group 2. Group 1 were patients who had laparoscopic sleeve gastrectomy performed and subsequently underwent a Roux-en-Y gastric bypass for post-operative GERD symptoms only. And by that, I mean any patient that had revision performed from a sleeve to a gastric bypass for any post-operative complications such as inadequate weight loss or complications like sleeve stenosis or leaks were excluded from the analysis. And the Group 2 were patients who all comers that underwent evaluation for a laparoscopic sleeve gastrectomy in the year 2016. And those, the number of patients were 269 in Group 2 and 59 in Group 1. In preoperative assessment, we had patients undergo a manometry and endoscopic evaluation, and routine standard findings were noted. As far as the classification of the manometric findings goes, the Chicago classification version 4.0, which is the most updated version, all our classifications could not fit exactly into the new classification, as some of the data we did not have the exact mapping, the Klaus plots, so we could not put it in the 4.0 version. So we just had to use and stay with the prior classification. So as you'll see the data, some of the diagnostic criteria, some of the diagnostic buckets we put these patients in are from the older classifications. The demographic slide on these patients, so there were only two standout points here. In Group 1, we had patients who had lower BMI compared to Group 2, and also correspondingly lower weights in pounds compared to Group 2 patients. Otherwise, the other demographic findings were quite similar between the two groups. The manometric findings between the two groups, Group 1, again, the patients who underwent laparoscopic sleeve to gastric bypass for post-op GERD, as compared to all comers who underwent evaluation for laparoscopic sleeve gastrectomy. The Group 1 had a much higher incidence of abnormal manometric findings, and by that I mean all abnormal manometric findings as a group compared to Group 2 patients. Now, breaking down these individual abnormal manometric findings between Group 1 and Group 2, the one that stand out finding was that the ineffective esophageal motility was noted to be much higher in Group 1 compared to Group 2, which was incidence was 20.3% versus 1.5%. And the only other significant finding was that the hypercontractile esophagus, which is now an entire category by itself and includes jackhammer esophagus under Chicago classification 4.0, was also found to be significantly higher. The rest of the findings of EGJ outflow obstruction, jackhammer esophagus, distal esophageal spasm were equally distributed between the two groups. This table just is a pictorial representation of the data. As you can see, the abnormal manometric findings were much higher in Group 1 versus Group 2, and the ineffective esophageal motility was statistically much higher in Group 1 versus Group 2. Endoscopic findings, as would be expected, I would say, the esophagitis as a bucket, meaning all A, B, C, and D LA classification, was much higher in Group 1 versus Group 2. When we break them down by LA classification, we only found LA Class A esophagitis to be much higher in Group 1 versus Group 2. There were no patients with LA Class D in either Group 1 or Group 2. Finally, the limitations of our study, understandably, the design is retrospective. We did exclude patients who had incomplete preoperative data. As I mentioned, some of the manometric findings are based on prior Chicago classification and hence could not be extrapolated to the most current classification. And then need for relevant comparisons, and by that I mean we chose 2016 as the year for comparison because that was the year we had the most robust and complete data to compare for, and we believe that our cohorts likely don't change from one year to the other when we're comparing those as controls. To conclude, I'd say the use of preoperative high-resolution manometry may be beneficial, predicting the development of GERD post-sleeve, and this can be a valuable tool in guiding surgical decision-making. Thank you.